Well, everyone, I am beyond ecstatic and excited to bring to you Univet's Ergo Advanced Loop. Um, as you know, these new Ergo style loops are the cutting edge, right, of loop technology, the biggest advancement in optics, I don't know, in maybe 2 or 3 decades. So what you're looking at right here is Univet's version of the Ergo loop. We're calling it the Ergo Advanced. And just in the chat box, out of curiosity, how many of you have ergo loops or are very, very interested in ergo loops? I would imagine, at least 8 out of 10, are actively probably looking. Okay, so there's one person in here that has one. Yeah, I mean, they're so cool. I absolutely love them. One thing I've seen and I like and I notice about these loops is just the position of the loop itself. Okay, it's in the bottom of the carrier lens. So if you ever look above your loop, right, to talk to a patient or a team member, look at an x-ray, check your work, grab an instrument, having the optics in the bottom gives you way more functionality out of your optic. And I'm excited to launch this product here in America and Canada next month. Okay, they're going to be available. The first opportunity will be ODA in Toronto. The second opportunity will be CBA South in Anaheim. And the third opportunity will be JDIQ in Montreal. And then Dr. Stevenson's probably going to be the first person in America to get his, because I measured him for his a couple weeks ago. So I'm ecstatic about it. We all kind of know the advantages, the ergonomic advantages of the loop, but obviously these ergo loops allow you to work upright. And before we had this term declination angle, and that was the angle that the loop was at, and that was a major factor in the ergonomics. But if you didn't pick the right frame or the frame didn't fit you, you still had to bend your neck a little bit. And so with these loops, they still allow you to work, pretty much upright. So we're slowly kind of progressing, right? The big difference, I would say, with our ergo loops and other companies' ergo loops is that you don't have to sit upright like a Buckingham Palace soldier. You actually do bend your neck about 3 to 5 degrees, and it's a very, very natural position. From an ergonomics standpoint, anything within 15 or 20 degrees forward is part of the optimal working position. So 3 to 5 degrees is a very natural position if you are looking down at your hands. And this is something that we developed off feedback from the original ergo loop design. So this is what they look like on someone's face. Again, you have a lot of room to look over the carrier lens. I personally really like this frame. This is our one frame. These are my sunglasses, actually, the same exact frame. That coating on the frame is the same engine coating that's on a Ferrari. So just a little bit of Italian style. And this version is called the Armando Portese edition, which is Paulo, our CEO's father, who founded Univet about 20 years ago. We're offering them in 3 different magnifications. All 3 of them have exceptional depth and field, just like you'd expect with any Univet loop. But the optics go from 3.5, 4.5 to 5.7. Dr. Stevenson likes his high mag, and so we just put him in that 5.7 right away because we know that's what he wanted. And this is kind of what I'm talking about the difference in the optical placement, which if you have used loop before, you know how important it is having the optic in the bottom. And you can see the big obvious difference with this and other companies out there. If you're wondering, about weight compared to our existing prismatic loop, they're all actually less weight than what we're offering comparatively in the original prismatic line. You just want to get an idea of what we're looking at in terms of magnification. This is what you can expect. But the best way to do it is send us a direct message on Instagram, come to the trade show, try them on, schedule a demo, and see this amazing loop that we're going to be bringing out. So, I mean, that's pretty much it. I'm going to turn it over here to Dr. Stevenson, and we'll get started. Thank you.
Okay, hi everybody. It's good to have you back. You are the real resilient ones that can handle all these hours that we spent on this. For many of you, it's pretty late at night already. So I'm going to get right to the meat of things. And we are going to be talking about, moving into the interior and discussing ceramic restorations in the interior. And I think that everybody really would love to know how to do veneers in their practice. I mean, after all, this is what you see on Instagram, is what all of your colleagues that do veneers, if you're not doing them, you're always feeling a little bit like, gosh, I really want to do these. And I just don't exactly know how to do it right. I don't know which course to take. I don't think I learned much in school. I've heard of people that have done them and had problems. I've seen results from labs that look artificial. I worry about them popping off or chipping. I don't know how to prep the teeth right. I don't know how to make temporaries. I mean, a lot of these questions are plaguing all of us, and they're all really legitimate concerns. And I would say that of all the dentistry that I do, and I do pretty much everything from surgery to orthodontics and everything that I full mouth rehabs, the whole thing, I would say without reservation that anterior veneers are the most stressful procedure that I do, the most stressful. And because they're stressful and because they're risky, and because they take a lot of attention to detail, you're going to find that your fees should probably be higher, and not just a little higher than a crown, but quite a bit higher than a crown. Probably we're looking at about 25% of our crown fee higher for veneers. And I think that I actually am undercharging. So let's get into uncovering some of these mysteries and some of these areas where we're a little bit perhaps resistant or nervous, or maybe, and I teach veneer courses, hands-on courses at my center, and these courses always sell out. They're super popular. I'm doing one in about a month for the Academy of General Dentistry. They're going to be hosting a veneer workshop here at our center. The course sold out in 3 days. So these are really popular courses to go to, that's for sure. But what I want to try to do with you is give you some of the background in how to look at veneers and start to gain a little bit of confidence in implementing them in your practice. And I remember what I was going to say. Many people already have done many, many veneers, but when they find out the wrinkles and the little insights that I'm going to present, they'll go, whoa, I've been doing some things wrong. And no wonder I have stained margins, and no wonder I get chips. And, oh, that's interesting. I hadn't tried that. And so even if you're an experienced veneer restorative dentist, I think you're going to find some things helpful in this particular presentation. My first veneer case was completed in August of 1986, 3 months after I graduated from dental school. At that time, nobody did veneers. So I've been doing veneers arguably now for almost 37 years. So if I can get my advancer to go, we'll talk. And really, this is sort of right out of Shakespeare, to veneer or not to veneer. That is the question, and it's really one of those things where you have to sort of think, is this a smart idea to do a veneer here, or could I do something more conservative? Or is a veneer ridiculous and I should do ridiculously too conservative? And should I probably look at doing a full coverage restoration? And, this is sort of dental, basics, the fundamentals, but I think it's really important for us to understand that veneers are there for doing shape changes and size and position issues. That we can take care of minor orthodontic alignment issues that maybe could be dealt with quite easily. Discolorations, but they're very challenging discolorations. People that get veneers because they want wider teeth don't really know what they're asking for sometimes, because when you have to make a veneer whiter, more bright, you have to prepare more tooth structure. And so sometimes the veneer becomes a little bit more than just a veneer in order to deal with discolorations. Malformations and defects, I think, are excellent. For example, think of a peg lateral, for example. What a perfect indication. Or other kind of enamel defects and things like that. Unaesthetic existing restorations, but that's a double-edged sword, because existing restorations usually have to be completely covered by the veneer. And now it complicates the case dramatically. And then sometimes black triangles. When you have some recession, you can sometimes treat cases with black triangles. And I'm going to share with you tonight an example of a failure of mine. I love showing failures because I think that they're more helpful than always showing everything being perfect. And so we're going to definitely do that as well. So some of the contraindications, and there are lots of them, is lack of marginal enamel. In other words, if you don't have a good enamel seal, your chance of long-term stain-free, chip-free success is reduced significantly. They can make it, that's for sure. It's possible, but you're looking at a reduced longevity, and your patients need to understand that they're taking a risk with veneers that extend onto the root surface, for example. Maybe you have minimal enamel internal. Perhaps the patient has had, some erosion issues on the anterior facial surfaces. They have a lot of missing enamel. Unrealistic patient expectations. We all have that patient that shows you a picture of themselves when they were significantly younger, and they'll say, I want to look like that. And you're like, okay, not exactly what veneers are going to do. Yes, we can probably roll back the clock maybe a decade or so, but trying to make somebody that's in their 80s look like they're in their 30s is not going to be possible. And we just have some limitations there. Vertical dimension is one of the huge ones. Sometimes we just can't open vertical dimension because it means that all the teeth must be restored, not just the anterior teeth. So patients ask for longer teeth, but we don't open up the vertical dimension. We change everything. We change phonetics, we change the occlusion, and quite frankly, those would be very dangerous cases to get involved in. If a patient has unresolved functional issues like bruxism, or maybe they have a constricted envelope of function or dysfunction, maybe they have some undiagnosed neuromuscular disorder. Some patients have chronic pain and things in joints, and these should be avoided at all costs. I think when orthodontics can be done, this would be a really a no-brainer. What I found is that patients that get orthodontics sometimes want to get the veneers afterwards anyway, and then at least allows you to optimize the results rather than try to push it with the veneers. I think minor orthodontic problems that would be, easily corrected with veneers is okay to do the veneers, right? But if we have a more major problem orthodontically, it really should be done right before. When bleaching will work, let's not give up on bleaching, even with patients that have had significant, disappointments in previous visits. Sometimes it's just because they're not managing the bleaching properly. They're not making the right kinds of trays. They're not using the right materials. They're not telling the patient to wear them long enough, or they'll get sensitivity and they have no remedies. But there are so many remedies now. We can usually get patients to bleach to get their teeth almost as white as they want. And then when bonding will work, good old bonding, I have U veneers, those little plastic shapes that can be used to make veneers out of composite. I can freehand them as an option. You can also use the new digitally fabricated cage that you close onto the front teeth that 3M is doing right now. There are a lot of things out there that can actually work for bonding. And if you're not an artist and bonding is kind of tricky, there are things that make you look like an artist, which is really cool. And those things are available. So there are definitely a lot of contraindications, Here's an example of a case that I did a long time ago. And this case was completed at UCLA, and I utilized the technicians at UCLA. They actually had a contest who could make the best looking veneers. So 7 different technicians all competed for this, and the one that got the best looking smile according to the patient was the one that got cemented. It wasn't the one I wanted, actually, which is interesting, but the technician won the prize for the best veneers on this particular case. But it was kind of cool because this patient had a lot of really kind of nasty looking bonding, and you look at this bonding all of these front teeth, and you may have an initial comment like, oh, you really had some really bad bonding done, but that's not really fair because you don't really know what the conditions were in which the bonding was placed. You also don't know anything about this patient's habits and what might have happened along the way or what they looked like. In this particular case, the bonding was done by his father, who was a dentist. So for me to have criticized the bonding would have been very unprofessional. And I think we need to be, as a profession, kind to each other as clinicians, because we just don't know what we don't know. The result, I think, was nice. It really was a life changer for him. These are beautiful veneers. These are the ones that did get selected. Like I said, they were not the ones I wanted. I wanted a little different look on the canines, but these were the ones that got delivered, and it was a life-changing experience for us. It was really cool. But when you looked at underneath the bonding, by the time all the bonding got removed, we had a good substrate, but sometimes you don't. You know, you have to remember, why was it done in the first place, right? I mean, what was it that got this young man to get bonding in the first place? Was it diastema? Was it irregular enamel? Was it chips? I mean, what was the underlying story behind the case? And so I think it's really important for us to be detectives and to make a decision as to what might have been the reason for the veneers, for the bonding in the first place. You know, typical patient, I have ugly teeth and old bonding. Can veneers make my teeth look normal? And my answer to this is usually, I don't know. I honestly say that. I say, I don't know. And they look at me, you know, what? You're Dr. Stevenson, you don't know? I go, no, I don't know, because I don't really know what I'm going to find underneath here. I don't know, maybe you've got really dark teeth, or, you know, why were these done in the first place? And she says, oh, I had shovel teeth. And I said, shovel teeth? What is a shovel tooth? I've never heard that before. She goes, no, they were kind of dished out. And I'm like, aha, this is somebody that may have had some enamel defects. So I'm automatic, you know, I'm right off the bat, I'm thinking, uh-oh, perhaps we've got substrate issues here. And so one of the things that's really important is to ask this patient, would you be, and these are the veneers, they turned out to be great. And these veneers were very beautifully done because they don't look like your typical Instagram veneer. You know, these veneers, the laboratory fee on each one of these veneers is about $3,000. And the reason why it was so expensive is because these teeth had to be made to look natural. The patient was harping on the importance of that. They were performed by Dr. Ed McLaren, who's a prosthodontist and a master lab ceramist. And he did these veneers for us and did a gorgeous job of making them look absolutely indistinguishable from natural teeth. The stains interproximal, the little chips, everything was done with great care. But you know, veneers were the ideal solution in this case, but I needed to be a detective before I said veneers can work. And the patient had to be okay with the notion that I may need to make super veneers or extended veneers. I don't say crowns usually. I'll say I may have to make a veneer that extends significantly more on the inside to grab onto more tooth. Is that going to be okay with you? And usually patients are sure, as long as it's not a crown. And I say to myself, well, is that a crown if it goes within a millimeter of the lingual margin of the tissue? Maybe. Some would argue that that's a crown, but as long as I bond it, it's made out of a monolithic material or cut back and layered, I'm going to still call that a veneer. So one of the beautiful shots that we like to do with veneers is the M sound or the Emma sound, or basically this is the repose position. John Coyce refers to this as repose. It's the position where you let your lips touch and then you drop your jaw open and you let your lips part, and then you then get to see the curtains are drawn, in other words, and you get to see exactly how much tooth structure it shows. And so for a female, usually about 3 millimeters to 4 millimeters, if you're up to about 35, 40 years old, is really normal. It looks really good. For men, it's about 2 millimeters less than that. And here she is with more of a high smile. And this is kind of an E smile. This is sort of a fake smile. We usually don't call this the E smile anymore. We call it the Pan Am smile. It's sort of the polite smile. It's not the highest smile possible. It's more of a polite smile. But you can see that the incisal edge position is proper, and they just don't look like veneers. And I think it's really cool. And then you can take the patient through all of the functional pathways and make sure things are going to be touching uniformly on both sides, particularly in protrusive, really critical. You don't want to have any of these border movements put too much stress on any one tooth. Sometimes you have patients that have, discolored teeth like this canine, and they think the veneer is a solution. Actually, veneer is not the solution to that dark tooth. That would be a really disastrous decision, because this tooth is going to actually get darker the more you prep into the tooth. What was done in this particular case is that tooth was internally bleached, and a lot of gutta percha was remaining in the coronal portion, which was, when I see that, I'm really happy, because that means that my chance of brightening that tooth up it's going to be more likely. And so we did internal bleaching on this individual, and then we did veneers because of the wear and the short incisal edges, the diastema distal to the lateral, some exposed restorations interproximally. These are the reasons why this got done. And so here you can see the problems, and then this is the bleach of that canine after the internal bleaching was done. I thought it was a pretty incredible result, but the patient still wanted the veneers. And so the teeth were prepared. These veneers, the preparations were done by me, but the veneers themselves were done by Chang, and Chang was one of Dr. McLaren's proteges. And the patient wanted really long oval shaped sort of teeth. And, you have to remember, veneer is kind of like a plastic surgery of the tooth, right? And whenever a plastic surgeon deals with a patient, they always ask the patient, what do you want? I can make you a round nose or a pointy nose, or I can make your nose more narrow or more wide, or whatever it is that you want. All of these things are up to you. I, the doctor, am going to try to accomplish what you want, but it's my duty to tell you what normal is and what normally, what usually looks good. And that's usually the way it works. And this is the particular design that she wanted. We talked at great length about different shapes and things like this. And I think they're fine. They're not what I would want for my teeth. But I thought that the result was actually very, very nice. When you have these shape, size, position issues where these worn incisal edges that probably start off as small chips, and then they got rounded off by dentists over the years. And then ultimately, maybe they started to wear because there was some enamel missing. These are the kinds of things that will sometimes drive somebody to say, hey, what can I do to make myself look better? And for her, we thought that probably something as simple as just 4 veneers would take care of her problem. And that's exactly what we did. These are they're beautiful veneers. These are done by Sam Alawi at Beverly Hills Dental Laboratory. And that's where you'll find Pascal Magnier now and Michelle Magnier, both working with him at his laboratory in Beverly Hills. I thought they were great. They're not super bright. The patient was very conservative. She didn't want to have bright white teeth. She just wanted to have the veneers that looked natural, that people would just say, oh, your smile looks better. What's going on? Rather than something that looked like such a huge dramatic change. Another indication, I think, would be fractures. Now, most of us would look at a case like this and say, well, these would definitely work out really well with direct composites. But both of these teeth were non-vital. They had to have root canal therapy, cores were placed, and she's like, hey, I just want something that's really going to last and not break that easily. What do you recommend? And I said, well, I really think you're better off with direct composites, but if you want something that's going to last longer, you're probably looking at veneers. And so she opted for veneers. And we'll show you that case in session 5, start to finish. And then other indications will be peg laterals like these. Although in my practice today, I don't think I would do a veneer on these examples right here. This is probably a really good case for a bonding procedure, particularly if the patient was young. So, but some people will come to you and say, no, I've already had bonding. I didn't like it. It broke, it stained, it didn't look good. Because, quite frankly, we as dentists just aren't that great at doing bonding, most of us. It's hard to do. Think of, how was tomorrow is Friday morning. If you have a patient at 7 o'clock in the morning and that patient needs a class 4 composite and needs to match the adjacent tooth, you are going to be a little bit on edge. I mean, that's not an easy procedure. It's going to take some time to do that. And so a lot of reasons people will go to veneers. And then here's another one of, this is a periopros rehabilitation. Periopros rehabilitation. I did not do the upper teeth, but I inherited this case and she hated the way this looked on the lower. So I actually used veneers on those lower teeth to blend into her existing restorations. And I think in terms of blending with the existing, Sam Alawi did a beautiful job. And I think we're really in good shape with this result, but these were done as super veneers, really wrapping around the teeth significantly. Sometimes patients want to look like something that they're not, and I think that this is going to be a problem to deal with at times when patients think that the rest of their face is going to change and look like Jessica Alba. And it's just not always going to happen, right? I mean, let's remember, we're dealing with teeth and we're not rebuilding the rest of their face. Definitely when bleaching will work. I hate to see cases where bleaching would have worked and the patient will go ahead and have veneers done. And I think that's an unfortunate situation that happens far too often. Sometimes you'll actually look at the before and after cases and wonder why were the veneers done even in the first place. And I think sometimes that does happen. So we need to be kind of mindful of being conservative and respect the fact that veneers are not a lifetime restoration in all cases. They can be, but not usually. Orthodontics, this is never, if the patient asked me for veneers, I would simply tell the patient, I'm not going to be treating you. I'm sorry. It doesn't matter how much you want to pay me and how much you beg me, I will not perform veneers on this case, no matter what. I won't do it. And I think that, we all have our breaking point. And this for me is a breaking point. Nope, you are going to get orthodontics. We're going to replace all those restorations first. And then we're going to take a look and see if you're in maybe bleach. And then we're going to decide whether you really even need veneers. And you may not even need them. So I would say that probably about 50% of the patients who come to me wanting veneers don't get veneers because of my decision. 50%. I've talked them out of the veneers. You may think I'm crazy, but think again. I've been doing this 37 years. There might be some wisdom within that statistic, right? If you look at, the patients that have unresolved functional issues like this case here. And a lot of people love to jump on cases like, oh, wow, this is great. Let me do a full mouth rehabilitation. I'll be doing bonded ceramic all over this person's mouth. I'm opening up their vertical. I'm going to do all this sort of stuff without understanding why it happened in the first place is beyond foolish, It's a disastrous outcome. A lot of the cases that I deal with are failed full mouth rehabilitations from general dentists, even prosthodontists that have not understood the exact reason why the teeth got to the way they were. So if we just look at the data and we look at the issues with failures, I think 87% success rate at 11 years is absolutely horrible results. If my success was 87% at 11 years, I would stop doing veneers. And the failure rate would get even higher when these patients had composites or they had any bruxism. And by the way, this patient in this picture right here probably does not have active bruxism. They have a completely different problem, which is something that's kind of beyond our discussion today. But that's more of an occlusion course discussion. Unresolved functional issues can definitely hurt the results for sure. When they were diagnosed with bruxism in this study, we're looking at only 93% at 10 years. I think at 10 years, our benchmark should be something like 98% success rate, 98%. So when you're looking at 93%, that means that if you did 1,000 veneers, 70 veneers failed over a 10-year period. 70 veneers. That means you're dealing with a failed veneer every 2 months. And I just think that's just too much. And then lack of marginal enamel, and I mentioned this earlier, sometimes, the patient is going to really push for some kind of a veneer in a case like this. And I'm going to push back as hard as I can to tell them no. And if they just say, well, I don't care what you say, I want you to do my veneers. And I say, well, you have autonomy to have veneers and decide what you want in your body. I also have autonomy not to treat you. And so I'm not going to perform veneers on you because I don't believe that they're going to last long enough. And I think you may say it's great now. And you say, oh, Dr. Stevenson, they'll be fine. I've heard about dentin bonding. Dentin bonding is amazing. Well, it's not that amazing. Okay. And so when we look at the results of cases where they were done well, you can get 96% at 10 years, according to this particular paper. But when they saw that enamel was not present, the success dropped off dramatically. And you'll have to read this paper to see the exact failure rates for those cases with lower enamel, but it drops off precipitously when you don't have good enamel margins. And this is kind of those shovel teeth I was telling you about earlier. And that one patient that she said, my teeth are like shovels. She had this kind of a defect. This to me looks pretty obvious, like lemon sucking or something like that, or maybe swishing with an acidic beverage or something like that. But, once again, 91% at 10 years, when you rely on bonding to dentin. And it's a huge problem. And it's one that people just don't really appreciate all the time. We've really been taught that, bonding to dentin is very achievable, and immediate dentin sealing and biomimetic approach, and we can have all these great results, but we just don't have really good clinical trials to support those kinds of statements. And the scientists that I interact with that are looking for better bonding to dentin are completely convinced that it's a train wreck, that it is very difficult to bond to dentin long-term. Short-term, sure, and we can have amazing results, but long-term bond is the issue. And let's face it, we want things to last long when the patient pays top dollar and it's for their smile, right? So another contraindication, it says, when you have a little funny little defect like this, I don't know whether this was a chip and it just sort of, or the tooth failed to erupt completely. If we look at the tissue levels, they actually look pretty good. So I think that they look pretty even. So I think that the problem was more of just sort of the one tooth just was made a little bit less long than the other. And it just was an easy bonding procedure to do. Here's one of the ones I really like to share, because this is a case that I took to Beverly Hills. I took the patient with me, and I had her spend about 2 hours with Michel Magnier, Pascal Magnier's brother, who's a master ceramist. And he took probably hundreds and hundreds of pictures. And then we talked about how can we solve this issue of black triangles, right? And so if you look at the teeth themselves, they're really beautiful. They're nice shape, they're long, they've got a lot of texture. I mean, I think they look fantastic. But the problem was the black triangles and some of these issues that make your smile look older than it really needs to be. Look, let's face it, it's not a porcelain issue, it's a pink issue, right? The pink is missing. We want the pink back. Well, the pink is not coming back because the bone is not there. So we're not going to get the kind of results that we want unless we were to, do some kind of magical bone grafting or tissue augmentation, which we all know is very limited in its success. So this case here got waxed up by the laboratory. And I took a look at the wax up, and it's a beautiful wax up. It's incredible. I mean, this kind of quality of waxing is really unusual to see this. And I looked at it and I said, really, if you go back to her smile and then look at the wax up here, what has really changed is just those interproximal areas. The way the teeth were in terms their shape was great. So it was just those black triangles. So I said, well, if that's the issue, why am I worried about veneers? I just need to do some composites. So you can use BioClear. You know, David Clark's got a great product. I think it works really well. But it's not, I think, as good as what you can do when you hand sculpt, like I'm going to show you here. Rubber dam was absolutely essential. The rubber dam is going to retract the papilla out of the way and allow us to build back in our porcelain and our composite in this case, and it's going to allow us a clean environment in which to work. I'm a huge fan of Estelite Omega. This is Tokiyama's top level composite. This is the composite that was developed by Newton Fall. And I think he's probably one of the world's best class 4, class 5 direct bonding specialists that we have in the world today. I love this system. It's magical, absolutely magical. You have to make your own shade guide. Like you see here on the lower right, you have to make it yourself. They don't sell you a shade guide. They force you to make your own shade guide. And going through that process, you really get to appreciate what the shades do and what they're like and what the composite feels like and the subtle differences in terms of manipulation between the dentin shades, the translucent shades, the milky white shade, and the enamel shades. It's incredible. It also comes with a DVD. If you buy this kit, you get the DVD. You got to watch all 4 parts of the DVD and watch Dr. Fall place composites. It'll blow your mind. And it just seems so easy when he's doing it. It's better than any YouTube ever made on the topic of class 4 and diastema closures that I've ever seen. So it's definitely worth the purchase almost just for the DVD. And he treats live cases, actual patients in this. So I'm using the Fall technique, and he always uses rubber dam. I'm using some Teflon tape that's the thicker Teflon tape, plumber's tape, and we're going through the process of recreating the interproximal spaces in this particular patient. And it didn't require that much. It was just a few little areas, and it completely changed the patient's smile. And I think that's something that we always have to think about when we're considering veneers, is what is the cost of doing the veneer, not just the financial cost, but what is the cost to the enamel? What is the cost to putting that patient in the restorative cycle, where a veneer that covers the entire facial surface of these teeth could fail, and all of that beautiful enamel that we had to take away in the process. So it's kind of nice to have this as an option. So, you know, advantages and disadvantages. Obviously, the cool thing about veneers is they're translucent and their natural appearance. Probably the best ones in terms of beauty would be feldspathic. But I've seen a lot of Emax veneers that look really good, particularly if they're cut back and layered with feldspathic, like we talked about in the previous sessions. Great conservation 2 structure. The bond to enamel is lifetime. It's amazing. That is a bond that we can live with for life. They can be very stable aesthetically, and they have proven longevity, at least, you know, if you consider 91, 92, 93, 94%, not even 95% success at 10 years, if you consider that a good restoration, then you'd be really happy. But I don't think that's enough. And I think we could do better. And so some of the things we're going to share a little bit this session, a little bit next session, our final session, is on how to make veneers last longer. The problems are veneers they're not reversible. Forget it. If you have to take off the veneer, you're not going back to the way you were. In fact, one of the worst things that you could ever face as a dentist is to have to take off somebody else's veneers. Or no, there's one thing worse: take off your own veneers. And I have done that, and it's a horrible experience, because it's very, very, very difficult to know exactly when you've just gotten through the cement and you're now back onto enamel, because everything matches so well, it's really hard to figure out. Fractures can happen, and high cost, of course. Fractures can happen if your occlusion is not managed, and that doesn't mean give you a night guard. That's a horrible way to treat a functional problem. So if somebody's having wear on their teeth and fractures and chipping and what have you, and you just throw night guards at them, you're missing the whole point. You're missing the point of diagnosis. And it's a sad thing, but we as dentists, and I'm included in this for many years anyway, when I didn't understand the problem occlusally, I'd make them a night guard. And I would chalk it up to bruxism. And that would be it. That would be my approach. And I think it's a very naive approach, and it requires, we need to revise that. If that's your approach, you need to think deep about revision of that particular approach, because it is not utilizing the best diagnostic algorithms that we have available to us. Okay, watch out for recession and stained margins if you don't use the bullnose etching technique that we have already talked about, but we'll show you how we do that again in this presentation, at least next time. So multiple factors determine success. This is really cool. The patient does, right? The patient's, if they're just a vertical chewer and they're not bruxing, and if they don't consume beverages that are going to stain the margins and these kinds of things, yeah, the patients can be great. And also they can have a really good attitude and say, wow, I love my smile. Thank you so much. And they're really happy about it. But they really have got to be financially capable. They've got to have reasonable expectations, and this got to be the indicated procedure, right? It really does. You really have to have technology working for you in your practice. If you don't have a digital camera, you can still use your iPhone. That's a digital camera. In fact, it's a great digital camera. You also want to incorporate digital smile design when you're doing veneers. And that doesn't mean you have to do anything special. It just means that you're going to be sending your images and a scan to the laboratory and allow them to work up your case with your guidance. And then absolutely, Devin, I'm sure you're happy about this, magnification. We've got to have magnification. It's imperative that you go with high magnification. And I mean, when I say high magnification, I mean at least 3.5, at least. I've been in the 5 to 6 range for 25 years. And it's not because my vision needed it, it's because I wanted to see more. And then I also use a microscope. So when I'm refining margins, the microscope is really helping. You're like, well, great, I can't afford a microscope right now. Don't worry. Your first step is to move into the best loops in the world, buy those loops, and then you can say to yourself, I'm doing what I can do at this time in my life. Remember, excellence is a journey, it's not a destination, right? It's about making progressive, you need to have this determination and make these progressive improvements in the way you do things. And it just requires lots of little steps, little steps, little steps. It's not like some magical thing you're going to do immediately overnight. Materials. I have burr kits. I use diamond strips, adhesives, and I use the best that I can buy. I don't ever go cheap on any of this stuff. I know there are a lot of knockoff burrs, and there are cheaper adhesives, or maybe there's an adhesive that has everything in one bottle, or cements that are easy to use, but maybe not the best. And I just never go there. I always just say, wait a minute. This is so important that we have to use the best of the best to make it happen. When it comes to laboratory support, they make sure that they are digital smile design capable. If they're not digital smile design capable, you may want to look around and consider a lab that does have this capability and understands it. I know that Beverly Hills Dental Lab does DSD, beautiful job with it. You could go to Christian Coachman and use the original DSD. It's not cheap, but I think it works really well for getting your patients to say yes to veneers when they're on the fence, or let's put it this way. I don't care if they say yes. I want them to know what they're going to get. And what DSD does, it allows me to prototype the case so I can place some kind of material into a stent, place it on their teeth, and let them see what it's going to look like. And then the technicians, it's up to them to deliver, because after all, they gave you the DSD, they gave you the digital smile design. You're looking at the case carefully, and they need to follow through. Labs need to have amazing customer service and master technicians. If your lab is shy about having the patient go there and get a shade, I don't think that lab is going to be the best lab for you for veneers. So patients need to feel comfortable going to the lab, speaking to the technician, and this is a must for me. So even with my out-of-town people will fly into California from all over the place, and they will spend about an hour at my laboratory, not my laboratory, the laboratory I use. I don't own the lab, but they'll spend about an hour there getting to know the technician, getting photographed. I take my own photos, but I want them to go there first. And then they've made a connection with that patient. And I think that somehow that helps. We can look at chair time. If you are in a fast-paced practice, by the way, I am in a fast-paced practice. I mean, I work really, really hard in my practice. There's not a spare moment. I am consistently working my tail off in my practice. I have one chair. One chair, okay? That's it. I worked in a 17-chair practice for almost 20 years. I know how to work multiple chairs. I'm not worried about that. What I chose to do, instead of seeing 17 chairs worth of patients and spread myself thin, I said, nope, I'm going to have one chair, and on the patients that are in that chair, I'm going to work my tail off on them. So we just do more work on patients rather than just doing little class 2 composites on 17 different rooms. We're going to be performing different kind of dentistry out of one chair. It's the ultimate, guys. I got to tell you. It is amazing. It is a great goal to shoot for. It may not be right now, but it can be in the future. And I think it's fantastic. Okay. And then finally, operator, commitment, passion, skill. How do you get commitment? You show up on a Thursday night in New York when it's almost 10 o'clock at night and your spouse or your roommates are wondering what kind of crazy dentist you are. You're listening to this webinar. That's insane. Aren't you like sick of that stuff? Didn't you want to do something different? Passion. Passion is about being open to being wrong and being willing to keep at it no matter what. So you have this hunger for wanting to be better. And then skill. And skill is not something you achieve by watching a webinar. I'm sorry. It's not going to work. It'll work a little bit, but you'll never reach your full potential unless you find yourself a mentor and get yourself into some kind of a hands-on training. And that's really the only way to do it. Of all of those factors, the most important is the operator. And this is not what most dentists would like to hear. Most dentists would like to say it's all those other things. It's not me, man, but it is you. And studies actually show this. They show that it was the dentist that was the most important factor at looking at survival of veneers being low in this particular study. And then another study, the veneers done by undergraduate students and staff members at Birmingham University in the United Kingdom, study reported that over 90% of the veneers were placed on unprepared teeth, and look at the success rate, only 47%. So we have to understand it's about us. It's about what our decisions we make. It's about our skill. Okay, let's. You know what, Devin? Why don't this is a good time for a break. We'll take a short break here, and then just about 5 minutes, I'll hand it over to you, and then we'll come back after the short break.
All right. Let's get back here. So before we hop back in, I want to take everyone just into this new product we have from Laris Research, the world's first voice-activated electric system called Perceptive. If you haven't heard of Laris before, they're a handpiece company that's been around for over 70 years. They're making their handpieces right here in California in Chico, and absolutely love the product, the company. I mean, they make the handpiece from scratch in Chico, and I think to attest to the product quality and innovation, I want to let maybe Dr. Stevenson maybe chime in a little bit what his experience has been with the system.
Yeah, we added 21 of these to our center. It's excellent. They also have a touchless capability. So you have a little miniature kind of tablet, like a little large, it kind of looks like a miniature iPad, and it's voice activated. So you can speed up or slow down the speed of the handpiece by just voice activation. It's pretty sweet.
Yeah, I'm really excited. We're going to be installing these into your clinic officially on Tuesday. I can't wait to see them. They're all going to look beautiful up there. What was the big adjustment or difference with the Perceptive system that you like personally, other than the voice activated? I mean, that's pretty cool, right?
Yeah, it's a well-made product. It's not bulky, it's lightweight. I mean, it's just a really good electric motor. I wanted to go with a high quality design, and I like the new technology that you guys have to go with it. So that was basically the reason.
I mean, we're honored and thrilled that you chose to work with us on that. So thank you. Before we get started, we did have a question from Faye. Says, hey Doc, hope you're doing amazing. I wanted to ask about the lower anterior recession case where veneers were done. Was the enamel enough from just wrapping around the lingual since the buccal margins were on the root surface?
They were done as super veneers, so there was a significant amount of lingual wrap. So they look almost like 3/4 crowns, more than that even. So wrapping around it approximately straight through and then down the lingual surface significantly to the point where they have almost enough retention to be non-bonded. And that's what I usually have to ask myself. If there's no enamel left at the margins, what's going to keep this in place? And we need to have some traditional resistance and retention form. That's a great question.
Gotcha. Okay. Well, screen share option should be back to you, and we can go here.
Okay. So there are some guidelines for veneers that are really critical. One of them is, no more than 2 millimeters of unsupported porcelain should ever be used. And this is true also of any all ceramic restoration. You would want to have your technicians create a core, if it was an all ceramic crown that was layered like a lava crown. The underlying zirconia should be made such that you never have more than 2 millimeters of a feldspathic type porcelain, a class 1 ceramic covering over that area. And if you need to have more than that in a fracture case like this, and which is going to be very challenging to do, you're going to probably end up doing buildups and things like that. You definitely want to go with Emax or go to an all ceramic crown. And with the Emax, they're going to be able to, goodness, here we go. With the Emax, they're going to be able to cut back and layer. You need to include existing restorations. So if existing restorations are wrapping onto the facial and onto the lingual, you need to go past those margins, particularly when they're large. When they're small, you can sometimes avoid that. For every shade change you need to make, you need to think about going another 0.2 millimeters. This comes from our laboratory technicians that have been working with this for quite some time. So if you have an A35 and you want to turn it into an A1, you have to prep quite a bit deeper. And if you have to prep deeper, then that could put you in a situation where you don't have enamel anymore. Otherwise, your veneers would have to look very opaque. Remember that zirconia is king when it comes to flexural strength, and porcelain is very, 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 very weak comparatively. So we don't want to have porcelain cantilevered out more than 2 millimeters. It's much more likely to crack and fail in those situations. But with lithium disilicate, it has no problem being cantilevered out more than 2 millimeters. So there's really no limit. So what you want to take a look at is what material to use. And if you're always thinking, oh, I'm always going to do lithium disilicate, I think you're limiting yourself quite a bit, because lithium disilicate can look pretty good, but it's not the best looking. And I think you're probably better off having a balance between the feldspathic and the lithium disilicate cut back and layered option. So I don't do just strictly lithium disilicate veneers. So they always have to be cut back and layered a little bit, at least to give some of that beautiful intrinsic staining that you can do with the feldspathic porcelains. Okay. So in your normal or nominal cases, feldspathic is the way to go. It's you're going to be forming a more conservative preparation. Your material is quite translucent, and you'll be able to build the color intrinsically. The problem is it's potentially weak, and you never want to have it more than 2 millimeters of incisal edge cantilevered. If you have to move into cases where you have to wrap more, like that lower recession case with on that perio-pros case, you're going to want to use something that's much stronger, like a lithium disilicate. When you start wrapping, when you maybe have to block out darker shades, it's nicer to use lithium disilicate because it has a better capability of blocking out dark shades. Remember that all the staining and all the nuances in, I have a train going by here. All the staining is all done extrinsically, not intrinsically. So lithium disilicate is monolithic, it's all one shade, and you're going to have to create this effect of translucency by cutting back the Emax and laying something on top of it, which is perfectly okay. And it's basically just called a bilayered veneer. And it's the only way I would use lithium disilicate for veneers, cut back and layered. And then if the teeth are really dark, you may want to consider even zirconia. We can bond zirconia. The bond strengths are quite good. Dr. Blatz, Marcus Blatz from University of Pennsylvania, he posts on Instagram all the time. You ought to check him out. He's got some really beautiful stuff. But basically what he's saying is that, this is a no-brainer. We can bond chemically to our substrate and have the ability to have a very strong veneer that also blocks out a lot of darkness in a very thin space. So I think that zirconia should be on the table for consideration for sure. When it comes to how long veneers will last, I'm not going to bore you with all these kind of studies. There's just so many of them. But basically what they all basically come down to is you're looking at sort of this range between 5 and 20 years, and 87% of the low end, 94% of the high end. And, I just don't think that's good enough, quite frankly. If you're getting only 87% at 5 years, that's definitely not going to keep you in business. You're going to have patients very upset with you. I think you need to think along the lines of getting about 98% at 10 years and maybe 96 or 95% at 20 years. Now you're really cooking. This is not too shabby. This is a great study, excellent with feldspathic veneers, looking at incredible results, 96% at 21 years. I really think that is kind of where we ought to be headed, or even better. The practitioners that participated in this study were prosthodontists and had the occlusion well maintained, well controlled, excellent fitting restorations, and they had everything going in the right direction. And I think this is basically what we ought to be doing. Failures. Let's talk about failures. I definitely have had many and have learned a lot. And I would say that tissue can be an issue. If we get recession and there's a black triangle, it doesn't matter what the veneers look like. They're gonna fail in terms of aesthetics. Tooth decay can occur around them, particularly with patients that have eating disorders, or maybe exposed to a lot of acid in their mouth. They can get a lot of caries. Aesthetics, sometimes the shade will change over time, and we'll get color changes, stained margins, things like this. We can try to prevent those but they sometimes occur for reasons that we're not really sure why. And that can definitely happen. I think that probably using the wrong cement is a big issue. A lot of people have trouble with discoloration if they use cements which were indicated for the posterior rather than the anterior. So one of the most important rules about veneers is always use a light cured cement. Never use a dual cure cement in the interior, no matter what the manufacturers tell you. I don't think it's worth the risk. And they definitely discolor over time, and that's well known. And then, of course, you have chips, fractures, debonding, these kinds of issues that can happen. So there's a patient that wanted to have some veneers done, and she'd had large root canals on her centrals. And this is, in my opinion, this is a failure. The black triangle there was something that I didn't really pay that much attention to. I just looked at the composites that were placed on tooth number 9, and then there was not a composite on tooth number 8, but there was a large lingual access opening, and our decision was to she wanted to have these teeth lightened up and made to look more even, and so the decision was to do veneers very, very carefully, but the preparations here are problematic. They look okay. I mean, they have good readable margins. They're in the right place and everything else. But the reason why I focus so much on preparing these carefully is because the size of the endodontic access on the lingual was huge, and I didn't want to perforate the enamel. That actually can happen. So the veneers were done by Chang, one of Dr. McLaren's proteges again, and Chang made feldspathic veneers very, very carefully so that he could block out the shade of the teeth and try to normalize the final look with a very conservative preparation. It was not an easy case for him to do, but I think he did okay. I think the veneers are fine. I think I failed because of my preparations, and it looks worse, in my opinion, tissue-wise at the finish than it did at the beginning. And let's take a look and see why that was. And I didn't manage the papilla. I'm not going to make the papilla grow, okay? But what I could have done is to wrap the margins around more interproximally, and then allowed the ceramic to touch in the middle at an area closer to the crest of the papilla. And so you can determine that very easily by understanding the crest to contact area formula established by Dennis Tarnow many years ago. And basically that when the bone is 4 millimeters away from the contact area, the most gingival aspect of the contact area, we're going to find that we get closure of that space 100% of the time. But as that distance increases all the way up to like 7 millimeters, only 25% of the time you will get closure. So it's a good idea in cases where you are planning on closing black triangles, or whether they're all ceramic restorations, full coverage, or veneers, that you pay close attention to the location of the bone and make sure that the bone to your contact area is about 4 millimeters, maybe 4.5 millimeters or so. And you can determine this either looking at it on the radiograph, or you can also just do bone sounding with the probe and find out what that is. And so the simple solution would have been to have wrapped the prep around and allowed the technician to have created this kind of a look, and instantly it looks different. I think this would have been a nice solution, but she should have also been aware of the fact that the veneers would look more rectangular or boxier or wider as a result, and not tapered like the original. The patient, fortunately, didn't care. This was not an issue for her. She just wanted them to be bold, bright, smooth, even, and mission accomplished. But I personally did not enjoy the result, and it got me to include this into presentations so that you can see the importance of at least considering this aspect while you're preparing teeth. So wrap the veneer more interproximally and avoid this issue. There's something called constricted chewing pattern, or you can also call it a pathway issue or envelope of function problem. And this can lead to a lot of early failures of anterior ceramics, anterior composites, and veneers. So I want you to be aware of this and talk to you about this functional issue just a little bit. So what can happen is when the patient is chewing, they wear their teeth in the anterior excessively, and you'll see this wear pattern that occurs on the lingual of the maxillary teeth and on the facial of the mandibular teeth. And it's so bad that when the patient bites down on their back teeth, they don't even feel comfortable. They want their jaw forward from where it is. It's almost like their anterior teeth have been over retracted by orthodontics, perhaps, or by maybe not even orthodontics. It could be just that their mandible grew more than their maxilla, and their anterior teeth trapped the mandible. And now they're in a position where the teeth are fighting the joint. And what ends up happening is joint problems, teeth start moving, teeth start wearing, patients feel uncomfortable, and it can really lead to a lot of problems. So this is one of the things that we need to be really, really careful of, is looking at situations like this and going, oh yeah, I have a patient that looks just like that. I'm going to do composites on them. Are they a good candidate for veneers? And this is really a case that needs to have the constricted envelope issue resolved before we do veneers. So no matter how much that patient wants to have something done here, we need to be really careful about diving into veneers in this particular situation. So it doesn't take that much. It's amazing what just a small amount of space will afford you in getting the kind of clearance that the patient needs while they're chewing. So it's not their MIP position, okay? It's not the contact position. It's the way, and it's not protrusive either. It's the way the patient chews. So if you're not looking at the way the patient is chewing, you would never see this. You cannot never determine this on an articulator, and you can never detect this by just having the patient tap, tap, tap on paper. You actually have to have the patient chew on something and put paper between their front teeth while they're chewing. And then you can see the actual chewing pattern and see if this is happening. So no patient gets veneers that has untreated constricted chewing patterns. They get into things like orthodontics, or sometimes they have to go into orthodontic surgery or new crowns or vertical dimension changes, things like that. These are usually cases that will haunt you for a long time if you don't take care of them. And this is kind of what they look like. They kind of look like this. And I know we all have patients like this in our practice, and we may look at those two centrals and go, oh, I can just put some composites there. You're going to be looking great, no problem. And you can shape the composite, make it look terrific, and send the patient on their way. And unfortunately, it's doomed to fail because of the functional pathway that this patient has. And some people call, oh, this patient's a bruxer, let me give them a night guard. So you give this patient a night guard, and they hardly even touch the night guard. If you look at the night guard, and they've been wearing it every night, and you look at the night guard, you'll see no wear pattern on it at all. And yet this patient continues to get this wear pattern on their teeth. Well, the reason is real simple. It's because this is happening while they're chewing, not while they're sleeping. So we misdiagnose this as bruxism all the time. So a word to the wise is take a look at this wear pattern and think about having the patient sit upright in the chair, have them chew on some gum, and put very thick paper between the front teeth, and look for the areas where the teeth are interfering. And if there's a lot of rubbing on those areas, then I would highly recommend that this be a case that would need to have intervention with orthodontics, or maybe a combination of orthodontics and posterior vertical dimension changes. You know, if you open up the vertical dimension, it can help it, but that can be over treatment. So probably orthodontics in most of these cases would satisfy the problem. Okay, this is a patient that's had a workup done. She has a miniature maxilla, a really, really small maxilla. And she really needs to have the entire maxilla pulled down. But the problem is she doesn't want to. So the only option here is to lengthen the teeth dramatically. So this is not an easy case at all. This is a case that most dentists passed on and said, I don't want to treat this case. the teeth are already good length in the mouth. The problem is they don't show. So the patient needed to have longer teeth to make them show. And to complicate matters even more, she had a space where this is a canine, this is an actual like supernumerary space where a primary tooth had retained, the permanent teeth had grown around the back, mesial and distal to it, and then ended up having that tooth extracted eventually. So she had an implant placed. This is a zirconia implant. I didn't place the implant, but I was stuck with restoring it. So I'll say that zirconia implants are a different ball game. They can be restored. I mean, I think the bone loves them, but the pros part of it, the components of these are tricky to deal with. So I'm just showing you here with, this is just a peak temporary abutment. And I'm going to go ahead and make her like a little cutback. And so after making her this little cutback, I just shaped this out of the mouth and then made it look like an under-contoured crown. And then we could then take a little shell like this that I made in my mock-up stent and then place the little shell on top of this in the mouth and then glue it together and deliver it as a personal. And then she could actually, at this point, have a mock-up made so she can determine if she likes the way her teeth looked, et cetera, et cetera. So, I mean, I think it's great. I mean, she can now, this is a patient that is in her mid-20s and shows no teeth, and yet the teeth are there, right? So we all know as dentists that this is a maxilla surgical problem, right? I mean, her teeth are the proper length, but they don't show. So this is the opposite of maxillary excess. This is the exact complete negative of that. So she has no opportunity for any teeth to ever show when she's in a rest position. So by adding teeth back in like this with this mock-up, we give her a chance to have a nicer looking smile. So although these are kind of strange looking veneers because they're really long, and I brought the veneers back to the premolars and then had to put a crown in that, she has like two canines. Even though the veneers had to be really, really long, they were able to provide her with more of a smile like this. And I wouldn't have picked this shade for me. I think an OM, this is probably, I think an OM1 or something. I think it's really, really bright, but it did give her better smile characteristics in her opinion. What about no prep veneers? Not a big fan, unless we have a good space for them. So remember that no prep veneers are going to add more volume to the teeth. And if you look at systematic reviews, I think this is really interesting. And this particular publication said that, out of 2,028 studies searched, not one article on no prep veneer survivability was found. No randomized controlled trials were done. That's pretty sad. And then also we know from much research that bonding to aprismatic enamel is much weaker than prepared enamel. So I'm not a big fan of no prep veneers. I think they've kind of come and gone for the most part. They were super popular for a while. Maybe some people are still doing them. I think that we need to prep. When we look at communicating to the laboratory, I call this the S7 series, and it's really simple. It's not digital smile design because they want to have a couple more photos in here, and I'll show you what those are. But in the basic lab photo series, I'll do a face, the smile, and the teeth. And so I do a portrait, repose, Pan-Am, Duchenne, and then retracted. You can see a number 5 and 6 and 7 are the maxillary mandibular occlusals. Okay. And we have to understand that patients have different smiles. And the smile you see there in the middle is really not a face smile. The one on the right is your true smile. So if you're basing all your decisions aesthetically on the middle smile, you're missing out on the reality of what smiles really do. So we want to take a look and make sure we get a Duchenne smile when we do these. So if you look back on this example here, you have 3 different smiles: a repose position, we have an E smile, also known as a Pan-Am smile, and then you have a Duchenne smile, which would be the lower one where they they smile all the way up and they get their lips moving completely and their eyes kind of crinkle and you get that true smile. The reason why it's called Pan Am is this is the typical smile that was seen by the Pan Am flight attendants in the early days of the airline. They had all this fake smile. None of these three smiles here are real smiles. They're all fake. They're all being told to show teeth and make it look like you're happy. But in fact, they're not. Look at these three students at UCLA. These are some of my grad students, and there's only one Duchenne smile. It's the one on the far right. The other two, the one in the middle and the one to the left, those are Pan Am smiles. And we do those far too often. We need to make sure that we get the Pan Am smile, perhaps to look at things like how the teeth lay in the mouth relative to the lip. I think that's fine. But in terms of looking at the maximum display and finding out how risky the case will be, you want to basically get a Duchenne smile. Let's talk a little bit about digital smile design. And I'm a big fan of Dr. Coachman. I think he's amazing what he's done, and has an incredible system here. You can become a member, and once you have your app on your phone and on your desktop or whatever, laptop, and now you can interface with this group of technicians, and they'll do different procedures for you. There are some amazing workflows that you can do and have everything designed digitally. You can have this interface with them that is just, it's basically, this is just like, you can, it's like Invisalign. You're managing your cases. You're taking a look at all the cases they'll provide you. You'll have this interaction with the technicians. And then you say, yes, it's a go. They give you sort of a mock-up and then you pay. You can see here on the left-hand side, it was 300 euro and 105 euro at one point. That was in 2019. That price has gone up a lot. And so digital smile design is something that you probably ought to budget, maybe $500 to $700 range is about what I've been experiencing for DSD, no matter where you go. This is what the digital smile design case workup looks like. They want you to have these kind of funny looking photos, and they can walk you through it. But basically you want to have these front photos with them smiling and then with their teeth apart. And then you want to take this photo from above called the 12 o'clock position where they're looking up at you. And then you just want only one occlusal photo. So this kind of it. And then they'll send you back a mock-up and you can spin it around on your computer and look at it and what have you. This is the Beverly Hills Dental Laboratory Digital Smile Design workup guideline for you. You can send them an STL file or you can send them a stone model. You don't have to scan. Okay. I like to scan. I've got a scanner and I scan everybody, but it's up to you. If you want to take regular impressions, you send it off to them in the mail. Okay. And then you just take those 6 photos. That's it. He only requires these six photos. Rest, smiling from the side, rest, smiling, retracted, and then he wants a 12 o'clock view like this. And what they'll do is they'll give you back a digital smile design workup that looks like this. This is what they'll send you back, this photo that provides you with these lines that sort of relate the distal of the lateral to the distal of the lateral. They're just trying to point out, hey, there's an asymmetry here. Where the centrals look really symmetrical and you're like, hey, well, I like asymmetry. That's great. I don't want those blue lines to be parallel. I want them to be a little different. So don't change that very much, or do change that. It just gives you the opportunity to see where they're headed with the case. So they'll give you back this sort of work in progress, and you can basically just tell them, no, I want to have the canines a little bit less pointy. I don't want to mess with the laterals. I'm only going to be doing veneers on the centrals and laterals. I don't want to mess with the premolars, for example. And that it's pretty cool. Then they'll provide you with a simulation. I mean, obviously this model here didn't need digital smile design for anything, right? I mean, the teeth look terrific, great smile and everything, but it was a nice, it's a nice example of a good looking outcome before and after. Let me show you a real one here. Patient does not have any teeth showing, which is very typical, unless she smiles. This is a Pan Am smile. and then Duchenne. And if you looked at her here, you may think that was her smile, but it isn't. She has to really get the crow's feet around her eyes. You need to have the muscles of the face completely contract and get involved in the smile, and then you know that you have a true smile. And this is the Duchenne smile. And so when you see this, you go, wow, oh my gosh, even though those teeth don't show in the repose, they do, the lip does move all the way up and show the entire length of the teeth. So is the entire length of the tooth important in this case? Absolutely. The other thing you can see in this image on the right is the edge to edge situation that you have in the central incisor and the lateral incisor on the right hand side. So both 7 and 10 both have a pretty interesting setback, and I think that kind of this crossbite in the anterior region on that side make it kind of tricky. So the teeth would need to have more preparation done. Does that make sense? So we say the word jump the lowers, jump the teeth. So if the upper teeth are back like this and you want to get them in front, you're going to have to prepare this tooth more to get that smooth transition from the lingual to the facial. And so here we are in a retracted smile. And then these are easy images to take. They're just called contraster images. You take a little black contraster and you insert it in the mouth, you take the photo, and you can do this with your iPhone and make beautiful photographs. And sometimes I'll take some other photos. On the right-hand side, I took the ring off of the camera and held it on one side only. So I get a shadowing so that I can expose some of the texture on the teeth a little bit. And sometimes it's helpful for the labs to have those too. And just a maxillary occlusal and mandibular occlusal. And then off it goes. And they'll give a workup on it. And so here it is. And they do the lines and they give you the symmetry. And then they show you how what the case is going to look like. She only was interested in anterior veneers only. She had just had some crowns done by somebody on the upper right. And she said, can we just do little by little? I said, sure. And then there's a simulation. So I think it's pretty fun to see this. And remember that it is a simulation. It doesn't tell you what the preparation design is going to have to be. It basically tells you what this might look like if it was performed. Okay. So the patient said, yeah, I'm willing to try this. Let's go ahead and I want to come into your clinic and have it tried in. And so I'm going to do something called a motivational mock-up. I kind of don't like that because it's really, I'm not trying to motivate them to get the work done. I'm more like a blueprint of what it might look like. How about that? Or what it may look like if we do things along the lines of veneers. But the biggest issue with motivational mock-ups or these mock-ups is they're all additive in nature. They're not subtractive, they're additive, right? So you're always adding back onto them. So they tend to make the teeth push out a little bit. And so sometimes patients are like, wait a second, this looks too much. I mean, these are too big and they're pushing out too far. But I want you to be just aware of that. So we're in this interesting time where we're all looking at these kinds of things to do. And they're not always smart, okay? Sometimes, you're not going to change the facial position of the veneer, and it should only add. So be careful what your lab does, because sometimes labs will just add more to the facial and bulk the teeth out. In her case, we needed to add more to the facial, right? Because her teeth needed to come forward. And so we're kind of doing a little bit of instant orthodontics in these kinds of situations. So we fill it up with one of your temporary materials. We get kind of a shade, we insert it in the mouth, and then we peel away some of the excess and just give her an idea of what she could look like. So I love this on the left because now she has teeth. In that earlier photo, she showed no teeth at all. So this is probably a pretty good case to do. Unfortunately, I placed a mirror in here to show you that the molars, the premolars, and the central incisors are all touching the mirror at the same time. So we have the laterals that are off the mirror, and all these, they're basically touching a flat surface. So we're getting a nice flat occlusal plane. Everything matches kind of nicely. And then we just peel it off and we say, okay, that's what we might have it look like. We don't bond it on. I don't like patients walking out with this thing. Okay. Some people go, oh, do you ever just spot bind it and let them go for a while and think about it? And I go, yeah, not so much. I prefer not doing that. You know, if they need to have other people decide whether they want to have the veneers or not, then give the photos to the patient and let them take them home and talk with a spouse or loved one or whoever else is in their life that may have a say in the matter. Okay. But unfortunately, she never got them done. Her son's a dentist. He didn't do them either. So neither of us did the veneers on her. And I think it was just because she just didn't want to go through the trouble, you know, and she came to, it's just people get kind of shy about getting things done to their smile sometimes. They're like, you know, I don't really need it. I'm okay. You know what I mean? It's sort of one of those things where they don't always get it done. This is probably the one case I've done in that I've worked up in the last decade that has not wanted to have the veneers done. Usually when we go to the motivational mock-up, they just want to see what it's going to look like before, but they've already said yes. Okay. So I have a workflow that involves 5 visits, and it's a lot. You know, veneers require a lot of workup. Your initial consult, your motivational mock-up, your preps, your delivery, and then you've got your post, you know, your veneer night guard type of procedure. And remember that the lab is going to be really busy too. They've got a lot of things to do. This is just another example kind of for tonight, just showing you some average cases, really. Visit number 1, a lot to do, you know, a lot of information to get. And this is just a rehash of the settings on the camera. I've refined these settings over the years. I think they're pretty good. The key thing is when you take the portrait photo, you want to have your camera set at autofocus. All the rest would be manual focus because your f-stop is your f-stop is so high that your depth of field is going to be tremendous. But when you're taking the portrait, you need more light. So you dial it back to f8 and that will be an autofocus image. This little critical 7 photo thing is so helpful, and in all the additional things you can do, like right side disclusion, left side disclusion, those really don't make that much difference. These are the photos I think that are really going to help the technician design the case better. It's just a case where the patient had some veneers done by someone else, and we have to understand that these veneers have been in there for 25 years, not a single chip. There's some stained margins. She's gone through some pretty difficult medical treatment, and she survived. And so here she is with these veneers, and there may be a little bit of staining here and there, but doggone it, for 2.5 decades, not a single chip and everything intact, no caries. That's pretty doggone good. Now, you may not like the fact that they're monochromatic, but for 25 years ago, that was about as good as a veneer got. So, but what her complaint was the canines and the premolars. And so this is just DSD workup, taking you through it, showing you how we're going to go ahead and work up the case, get some optional areas of interest. And on the lower, she's missing a tooth. There's a root fragment there on purpose because she's had IV bisphosphonates and she's not a good candidate for implants or exodontia. So her physician and I both agreed that just allow the tooth to exfoliate after endo. And that was the way that was treated. But you look at the upper teeth, the canines look pretty straightforward, except there's some wear on the lingual of the canine. So when you look at those 4 teeth, probably tooth number 4 is going to be some kind of MOD onlay / veneer called the vonlay. On tooth number, let's call that 4. And tooth number 6, it's going to be more of a wraparound, almost like an entire tooth. It's going to get, it's going to wrap quite a bit on the lingual. On the other canine, it's going to be a slightly different design. It's going to be more conservative. And then on the final one, it's going to be kind of a bit more like a crown. but these were all done with Emacs. There's that typical DSD workup photo. And we scanned, sent them off, and then the laboratory goes ahead and works up the case and sends me the nice little communication. And they show me before the original with all the lines and pointing out asymmetries and things like this. And then they just threw the teeth in here. And I thought that was awesome. And so when I showed this to her, she says, that's it. That's what I want. And so it was pretty easy, you know, and the hard part was trying to keep these as veneers. And I promised her I would do it. So, you know, when does a veneer become a full crown? As long as I'm bonding it and treating it like a veneer with light cured cement, and my preparation design is conservative, then I'm saying that's a veneer. So there's a simulation, and then here they send you the simulation models, how they're going to bulk out her area, and then we're ready to try in this motivational mock-up, as we've talked about already. And so here she is, and then there's the putty matrix. Oh, by the way, you notice how there's two different materials here, two different colors. One is a low viscosity and one is a higher viscosity. So these matrices are made with a very accurate initial layer and then a more stiff outer layer, and they work really great. They have to go in the mouth, so they're pretty bulky, but they get in there, and then the mock-up is just the premolars and the canines. I thought it looked pretty good. So I told her, you know, this is what it's going to look like. What do you think? And she said, I'm all for it. And then we just pop off the mock-up. It just comes right off, and then we're ready to rock and roll. Now, a lot of times, if you've budgeted the time in your practice and you're pretty sure they're going to go for it, you can use this. You can start prepping right here. And what I typically do is, if I know the patient's going to say yes to it, I can start preparing through the motivational mock-up. In other words, use that as my guide, because a lot of these cases we're building back out, right? We're making the smile more full. So I can prep right through it. Laboratory may need to modify it. Sometimes we have to send it back and say, no, it wasn't right. And we've made some changes and we've rescanned it. So now use this as the new motivational mock-up. You have to be willing to go that extra distance to make it happen. Someone just swooping into your practice, getting the veneers prepared in the first day, putting some kind of temporary and sending them on their way is never going to be a good way to go. The preparation appointment is pretty stressful because you've got to prepare a lot of teeth, you've got to take impressions, you've got to make temporaries, you've got to take photos, it's just a lot. And so budget the time accordingly. Then the laboratory is going to make the veneers for you. Hopefully they're going to tell you everything looks fantastic, and you're not going to get that phone call after about a week that says, hey, we don't have enough room here, or what are we going to do about this impression? There's a margin we can't read. Hopefully you don't receive those kinds of phone calls. And then on the clinical appointment for delivery, presumably everything should go nicely because the patient's already said yes, right? They've already said yes to your mock-up. They've been walking around with your provisionals for the last 3 weeks, and your provisionals were based off your motivational mock-up, and they've already liked it. Now, if during that phase, all of them start breaking and falling off, that's not a small, trivial matter. That means something might be wrong. That means that maybe there's a parafunctional habit you were not aware of, or maybe this patient has a constricted chewing pattern, or maybe we haven't really understood that they are bruxing and they're bruxing at night, or they're bruxing during the day. You know, so if those situations happen, I would caution you to say, uh-oh, something's wrong here. You're breaking your veneers, and I've just put them in, and these are temporaries. Then the solution is not to make zirconia, right? So that's kind of the knee-jerk reaction that we have sometimes as clinicians is things are breaking. It can't be my fault. It must be the material fault. Therefore, use a stronger material and everything will be fine. And that's really not the case. So we just attach these veneers to these Optra sticks, and then we can treat them all with etch. I'm going to go over this in our next session on the details of how these get delivered, but just apply silane, and then the veneers get delivered, and you can see the yellow arrows where the veneers are placed. And, you know, she had a nice result. I thought it was pretty good. And then we go ahead and make a veneer guard. I like these soft, hard guards. And rather than the hard ones, I like ones that are a little bit soft internal. And be mindful of printed guards. I think a lot of printed guards are too bulky. I like the old school guards, even if they're, thermoplastically made but trimmed and have the guards made really smooth and flat on the chewing surface. So whatever your lab is doing, a lot of them are getting away with printing guards for you, and they're all bumpy. So when the patient bites down, they're feeling bumpy. You want to make sure that they can move around easily. And then the veneer delivery, your maintenance plan, your guard gets delivered, check on the veneers. Sometimes you'll find some excess cement that you couldn't get to that day. And we're going to go over all those techniques of how to deliver the veneers and all the details of that in our final session. I like to tell them, wear it every night, and if you don't wear it and things break, I really can't guarantee your veneers. You need to be wearing this even though you're not a bruxer. Now, if they are wearing some kind of sleep appliance, then of course you're not going to have them wear a veneer guard. You'll have to make them you'll have to redo the sleep appliance, right? But the one I really like is the one that's kind of soft. The company called ProSomnus makes one called the Evo Select. And if the patient needs a sleep snore device to wear and you just made veneers for them, you'll have to scan them in, and then this company is fully digital. So it's real simple. You just scan it, send it off on your iTero or whatever scanner you have, right? And then fill out an online prescription, and then they'll come back with a beautiful, very soft, comfortable appliance called the Evo Select if you needed to make a sleep appliance on a patient that had veneers. Yeah, and that's, I also tell the patients, look, if you like red wine, you're going to really challenge my veneers, it's going to be really tough on the veneers. And so is tobacco. Tobacco is really tough. It's worse than coffee. Coffee is probably not even as bad as tea, so tea, berries, soy sauce, red wine, but red wine and tobacco are got to be at the top of the list for staining. And I think that's basically all I had today at this point. So I'm going to hand it back over to you, Devin. And if there are any questions, I'll try to field those at this point, and we can wrap it up.
All right. Thanks, Dr. Stevenson. That's awesome. Question from Faye. Let me open up the chat box here. Is choice 2 still your go-to cement for veneers?
Yes. Love it. Love choice 2. The reason why I really like choice 2 is that it's super color stable, number one. Number two, it matches the try and paste so nicely. It's one of the few that really, really matches. And the third reason why I really like it is it's pretty viscous. And I like viscous cements because they don't get all over the place and you can clean them up nicely. So I think that Bisco has hit a home run on that cement. It still is my favorite.
Nice. Faye, where are you located?
I'm in California. Southern California.
I want to know where Faye's located. Oh, she's in Austin.
Oh, okay.
I appreciate the questions.
I thought that was a place.
And the other 64, attendees that are still sticking through the webinar series with us, thank you so much. We appreciate it. If you haven't been to Dr. Stevenson's Teaching Institute in San Dimas, California, go to his website, get signed up before the course sells out, in a couple of days, like his gold course, and come visit us at your next trade show. ODA, JDIQ, CDA, we'll be there. We're going to have our new loops and the Alaris electric system. So thank you, everyone, and have a great evening.
Thanks, everybody. Take care.
Thanks, Dr. Stevenson.
You're welcome. My pleasure.